for the session. I'm Andy McLeod, anaesthetic consultant at the Marsden, so I look after patients having major surgery with an interest in ethics and law, so I'm trying to counsel them beforehand as well. So we're delighted to have Mr. Bertie Lee join us, who's, you can describe, what's your interest in consent and what's your background, Mr. Lee?
Well, I've been defending doctors and hospitals for over 40 years, many of them charged with allegations that they failed to obtain proper consent from patients. Almost none of them have been accused. I can think on fingers of one hand of the number of times I've actually had a doctor who was accused of not having the consent to an operation at all. But it's routine for patients to complain that they haven't consented. I've also got a broader interest in medical ethics. I was chair of NCPOD for some years, and I've worked on patient safety, and I advised 3 Royal Colleges on issues of ethics and patient relationships. I'm also chairman of the Clinical Disputes Forum, in fact, and we've done a project in the light of the Montgomery case on what's wrong with the consent form and how we can improve things.
Well, thank you for bringing your wealth of experience and expertise to us. I mean, I'd still hear colleagues say, I'm going to consent a patient. So broadly, what do you think are the major shortcomings of consent as it's practiced in the UK now?
Well, of course, they're not going to consent a patient at all, are they? They're going to counsel a patient before the patient consents. And when language is systematically used in a wrong-headed fashion, it usually is a sign that there's something else wrong with their understanding of the process. Patients don't usually need to consent to surgery. I think we should get away from the whole idea. Consent is a means of creating a defence to a charge of assault. Now, when a patient comes to see a doctor, they're not thinking of charging them with assault, nor should the doctor be concerned with creating a defence to such a charge. What the patient is coming to do is to say, help, I need an operation, or I think I need an operation, I don't know if I do. I want you to advise me, and when you advise me as to whether I have an operation, you should be telling me about the advantages and the disadvantages of this procedure, and what are the alternatives and what are the disadvantages of that. If a patient goes to see a doctor with a problem and they decide at the end of that consultation not to have a procedure and they go away with an aspirin or just advice, they have taken a clinical decision. And because we are hung up with this idea that the doctor needs a defence to an assault, there is no record made of that decision or of the advice that has been given. There will be a record made of the symptoms, there will be a record made of the findings on examination, the advice. There may be some record of the circumstances in which they should come back, the safety netting, but there will rarely be any record of the real advice that has been given. What are the risks of conservative therapy? In Montgomery, the case that went to the Supreme Court, which has set everyone thinking about this afresh, Mrs. Montgomery was not asked to sign a consent form to procedure because she wasn't asked to undergo a procedure. She was going through a normal delivery, and you don't get a consent form.
Do you think patients maybe come in with too low an expectation? Most patients just feel, I need to sign something or I won't get my operation. Do you think we need to change patients' expectations?
And it's not like that. I know people think that one of the problems with antibiotic excess use is that patients feel that they're vindicated if they're given an antibiotic. It proves that they were right to go and see a doctor and that there is something treatable wrong with them. I honestly don't believe that your patients go to see you saying, I want to sign a form, and there will be something incomplete about our encounter if I don't sign a form. Anaesthetists, by and large, don't ask patients to sign consent forms very often nowadays, because we found that they were being left vacant so often that I thought it was a sign that there was something wrong with the process. If you've got an unfilled consent form in the clinical notes, then that's a sign that the process hasn't been gone through. So I advise that we ought to get rid of anaesthetic consent forms.
Yes, I think maybe some of the audience will agree that there are many patients, maybe from our British heritage, just have an expectation that you go to hospital to be treated and you'll place your trust in the doctor and sign the form. We see that every day. So do you think that needs to change?
Well, apart from anything else, NHS financing says it needs to change. We've got to get the management of health out of hospitals. it's wrong to think that the decision to undergo an operation is a peculiar and extraordinary thing. When a patient goes to see a doctor, they're going for advice about their health. It doesn't matter whether they're going to see a nurse, a GP, a surgeon, or an anaesthetist. They're going for advice about their health. In most cases, the advice will not be that they should undergo a procedure. I go and see my GP and he gives me advice. That's what I go to him for. Occasionally he may give me a pill. Occasionally he will refer me to a hospital. But we've got to get far more medicine out of hospitals, and we've got to get far more medicine preventive. Most of the important decisions that I take about my health in my lifetime are taken by me at home. The reason why my life expectancy is 20 years longer than my father's is because of changes in society and the way I live, the fact that I don't smoke. If you read Michael Marmot's latest book, Health Shock, and he talks about how America has this disastrous health system. They spend double what we spend on the health system, half of it in the last 6 months of life, so it's really a death system. But they have lower life expectancies than us. And he looks at why that is. It's obesity, it's smoking, it's alcohol, it's auto accidents, it's gunshots, it's all sorts of other things that interfere with life. And if we're going to have a healthy population at a price that we can afford to pay, we've got to get health back into the home.
I'll come back to America and consent a little bit later, but back to the Montgomery judgment. I mean, it's been said by many that it's just restating GMC guidance. So do you think this will change practice?
It certainly is restating GMC guidance. The crux of the Montgomery judgment is that you as a doctor have a duty to advise patients about the advantages and disadvantages of the alternatives to treatment. The unwritten bit is that you've got to create defensible records of that process, which is also problematic. But that reflects what's been in the GMC's guidance from consent in 2008, and indeed that case is the only case that we've had in a civil negligence action where the GMC has intervened and become a party and gone to the Supreme Court and said, we are here to say what good medicine is. If there's one thing that I want to get across to you today, it is that I want you to concentrate on being a good doctor and not a bad lawyer. You're not there to try and create a defence to a charge of assault, because that's not your job.
Yes, David.
Do you feel with the forms of the trust, do you think a health service trust would have the same view of its employees and its staff? What are, in your views, the expectation of the trust regarding consent?
Well, first thing I say to you as a doctor is that you are professionally accountable to your own professional body for what you do, and if the trust is telling you to do something that's contrary to your own medical ethics, you have a duty to a higher authority to say no. So if there were a valid antithesis between your obligations to the trust and the profession, you must put your obligations to the profession first, your obligations to your patient. But I don't think that's a fair antithesis. I do think that the trust has got an utterly fundamental problem about how it's going to discharge this obligation to its patients.
So there's lots of questions that arise from that. The Montgomery judgment itself said we shouldn't bombard patients with information, but often trusts and the NHS Soleil will be wishing more and more risks to be added to our counselling process to the hope we can avoid liability, like the American consent form we mentioned earlier. So do you see a danger in this, that more and more information will be loaded onto patients?
Certainly there's a danger of that, but step back. If you look at the patients who come to this hospital, absent paediatrics and obstetrics, more than half of them are aged over 80, they've got 4 comorbidities, they're cognitively impaired, they come here for help. You've also got people who have come in with an acute injury after an RTA, they've got a space-occupying lesion in their head, they need to be told they'll be dead in the morning if they don't have an operation. You've got a very broad group of people. You've also got the fact that 25% of them don't share a language with their doctor, and that those 25% share 75 different languages. Now, you can either give up and say, all right, if I shout loud enough, I'll satisfy myself that they understood. Or you can say we've got to recognise that we have professional obligations to these people and face up to how we're going to discharge them. Now, I don't suggest that David, in an outpatient clinic, should be conducting seminars on medicine for his patients, but he does have to face up to the real problems, and the trust has got to face up to them on his behalf, because I don't believe that the obligation that the doctor now has to counsel patients, to educate patients, to train patients, I don't think it can be carried out in the outpatient clinic for all sorts of reasons. First place, when you go to an outpatient clinic, you're usually being given bad news if you're asked to undergo an operation, so you're pretty frightened. You know that the doctor's got 30 other patients waiting to come in, and therefore the doctor's pressured, and you don't want to take up too much of his time. We know that in those circumstances, patients do not lay down information. There's admirable research which documents what patients recall of what they were told before surgery, not when they're bringing claims, but in controlled circumstances when nothing's gone wrong. And the answer is that patients' recall of information is grossly inadequate. First time I read that research, I thought, my goodness, I can defend doctors with this. I show it to the judge and say, believe the doctor, not the patient. And I still think that's a fair proposition. But it doesn't discharge the obligation of the doctor, because once the doctor is fixed with that knowledge, then the doctor ought to accept that you cannot counsel a patient, and the trust should accept you cannot counsel a patient adequately in those circumstances. What you've got to do is to take the burden of communication outside the outpatient clinic, and you've got to recognise that a patient who is on a standard model, let's start with the standard model of the competent adult English-speaking patient who's reasonably educated, and start with that, because once you've got the standard model right, then you can recognise what deviations you have to go through to get to a position where you're dealing with the problems of communication and where you have to depart from it.
Many patients we've all encountered who just don't want to know. Now, there's a difference between afterwards what you regret you might not have heard, but beforehand, when we're trying to advise and counsel, we've all encountered patients who, I just don't want to hear any more, doctor. How do we accommodate them into this sort of process we're aspiring to?
The Montgomery judgment has an explicit paragraph which gives you a let out for that effectively, and it says that if a patient says, I don't want any details about this, I leave it to you, then you can shape the information that you provide to them to deal with that. I'm not sure that in 30 years' time or 15 years' time, Montgomery judgment, remember, concerned facts which occurred 15 years before it got to the Supreme Court. If the Supreme Court comes back to this problem in 15 years' time, I'm not sure that we won't find the goalposts have been shifted, and that they will say that it doesn't matter really. See, when I go and hire a car in Italy, and I turn over the form and I look underneath it and I see it's printed in 6-point Italian. Now, I'm afraid I don't speak Italian, and my eyes no longer allow me to read 6-point. Now, I could say, right, I'm going to sit here, I'm a lawyer, and I want an Italian translator to come and explain this to me, and I'm not going to do it. Do I? Of course I don't. I want the car. And just like me, the patient who goes into an operating theatre wants to get rid of the pain. They want their disease treated. Now, I think that the doctor has an obligation to say, slow down. I am here to advise you about how to live your life. I can perform an operation for you, but that is think of it as an analogy between the man who gets the great liner out of Southampton water, out of the harbour, and then hands over to the captain who's going to take it across the Atlantic. You're the pilot. You will get the ship out of the Southampton water, but I've got to live my life. And your advice is only valuable. Your intervention is only valuable if it helps me to get the rest of the way across the Atlantic. And you're not going to do that for me. You're simply going on one day to do one minor procedure which on my body, which may or may not be advantageous to the longer voyage that I'm undertaking.
Yes. I mean, the law is very vague on what we specifically should warn a patient. I suppose it can't tell us, but where does that come from? What we should, what the...
Well, I think that's reasonable. The law always judges things in retrospect, I'm afraid. You show us a set of facts. First of all, we have the argument about evidence, finding out what the facts are. And once we got them, then we put them into a broader matrix. Now, when you are counselling a patient, I can't tell you precisely what risks you should mention. In the Sidaway judgment, there was talk about how it was a 1% risk that you had to mention. That was always nonsense, because it may be a default starting position, but the risks you should mention are dependent on a fasciculus of things. There's, first of all, how serious the risk is. Blindness or death is obviously more important than the fact that you're going to leave someone with a few hours of pain from giving them succinylmethonium after a procedure. So we've got a continuum of severity. Next, we've got how much choice have they really got. The patient with the expanding subdural in the accident department tonight hasn't got very much choice, whereas the patient who's having cosmetic surgery has got all the choice in the world. And in America now, where they do have some of the proposals that I've been talking about in some circumstances, you can't have cosmetic surgery from a fellow of the Association of Aesthetic Surgeons unless you've been through an MCQ test and proved that you understood the risk.
I was going to ask, do you think this is putting or asking a higher standard of patient engagement? Do you think you're almost setting homework to say, I want you to show me that you've understood this set of risks I've shared with you?
Absolutely. You are my teacher. That's what I come to you for. I come to you to get your knowledge applied to my problems. I'm the only person who can apply it, and you have got to teach me. And I think the relationship is not... I think when you saw someone sign a consent form and you tell them they may get infection, hemorrhage, death, venous thromboembolism, and you don't explain what these things mean, I think that's the equivalent of teaching in a primary school, where you stand in front of a class, you give them the knowledge, and then walk out of the room and take no steps to find out whether they've understood it. No one must think that's an adequate version of teaching. Teaching involves imparting information, educating, and that means going through a process and establishing they understand. Now, when you're dealing with adult or competent patients, you are not talking to them, teaching them like primary school children. You're teaching them rather like an undergraduate seminar. And the basic work of an undergraduate seminar is done by the students before they go into the seminar room. And your job should be to find out what homework I've done, and then to help me to clear up the problems of understanding, because some of the things that you have to explain to us are profoundly complicated.
Yes. David?
Are you saying that the consent process as it stands is disingenuous, in so much as you give a whole raft of data to patients that they're ill-equipped to understand and make a rational decision? Or are you not going that far?
I wouldn't say it's disingenuous. I would say that telling someone that there's a risk of hemorrhage, infection, or venous thromboembolus tells us absolutely nothing. Hemorrhage.
Agree.
I may bleed. You're going to cut my body. Of course I know I'm going to bleed. Hemorrhage, what does that mean? If you don't tell me the difference between a blood loss of 25 mils and a life-threatening hemorrhage, and explain to me what that may mean in practice for me, you have not given me any useful information. Venous thromboembolism, most lay people do not know what that means. They do not realise that it may mean pains in their legs, that it may mean a life-threatening loss of ability to breathe. And unless you give me information which is useful, which is how do I minimise that risk at the same time and put it in context, it's not a meaningful exchange of information. And anyway, when I go and talk to Andy and he advises me to undergo a procedure at the Marsden because I've got cancer, I'm not, frankly, going to be very concerned about the remote risk of bleeding and thromboembolism. A man of my age, I'm most likely to be going to him because I've got an elevated PSA. Now, when I go and have prostate cancer surgery, there's a paper in the New England Journal last week which says that if you randomly allocate people with an elevated PSA and follow them up for 10 years in England, this is 47,000 people, and you allocate them randomly to surgery, to radiotherapy or follow-up, the differences in outcome are not very significant. There are differences, but you need a higher degree in maths to understand them. The number needed to treat to avoid one mortality in 10 years is 33. And it seems, in fact, that radiotherapy may be better than surgery. Now, I don't think most surgeons understand those statistics. And I think that if you're going to put that information in my hands so I can make a useful decision, you've got a really difficult teaching job on your hands. And to cluster it up with talk about hemorrhage and venous thromboembolism and infection is just distraction. I think that we ought to, the whole point about consent is that it's creating a defence to a doctor against a charge of assault. And that's not what I am thinking of doing with Andy when I go and get consent to undergo surgery for prostate cancer for him. I really won't be thinking about suing him for assault. I want him to do the operation, but I want him to help me to decide whether it's a good thing for me or not.
And the Montgomery judgment also stresses it's advice. It's about things you might find significant, not just things that might change your decision. So it seems to impose our duty of counselling in a much broader setting than simply the risks that might come up later in court.
Mrs. Montgomery, of course, said that she should have been offered an operation. She should have been offered a caesarean section, and she wasn't. And she wasn't asked to sign a consent form at all, of course, because she wasn't consenting to a procedure. She was going to be put through a normal physiological process. It did, in fact, involve surgical interventions, Von-Teuse and so on. She was not being asked to consent to a procedure, so there was no consent form made and there was no detailed record. If a woman goes through a 9-month antenatal process and at one point gets to see a consultant because there's some problem on a scan or some difficulty in the second trimester, this will be a sophisticated interaction. The only time she will meet a consultant in her specialty, and very often the advice will be, the record that will be made is see midwife next week. And that is the only record of a sophisticated educational process.
So we've had a great conversation so far, but we've almost used more time than a typical doctor will have with a patient. Do you feel any sympathy for David with his 10 patients in his outpatient clinic?
I feel an enormous amount of sympathy, but I feel a great deal more sympathy with the patients because David is the one who has designed the process and he owns the process, or his employer does. And to try and counsel 10 patients in the fashion that I've been describing in a clinic, it's not realistic. What he should be doing is, first of all, should try to ensure that the general practitioner or whoever sees the patients before him has equipped them for that consultation as well as they can. Then he should be using that precious interval to give me a reading list, to send me off with work to do. And when I say a reading list, it should be directions to go to various websites, to places where I can find the information that I need. For example, one of his colleagues in the National Hospital here has a particular interest in cavernoma and trigeminal neuralgia. These are two very active patient groups and they've got websites. And if you go and visit their websites, who do you find talking to you but Mr. Neil Kitchen, the neurosurgeon you will see when you come to the National Hospital. And he will be helping that patient group to explain to other patients, because patients are enormously valuable in communicating to each other the disadvantages.
So do you feel IT and all the potential now of internet has a big role to play in helping this process?
Absolutely. One of the problems we have, Mrs. Montgomery was a woman suffering from gestational diabetes. There's one teaching hospital in this town that has a special clinic for gestational diabetes. And I was talking to the person who runs it, and she told me that the average reading age of her patients is 6. Now, don't knock it. With a reading age of 6, you can read The Sun, but 50% of them have got a reading age of less than 6. However, they have assets. They have a better grasp than I do of how to use their iPhones. And if you have an app, if you use the assets that are available to communicate with those patients, then you will be able to do it much more effectively than by giving them large quantities to read. And you can also do it in their own languages. Her patients, she has 25% of them don't speak English, and they share 75 different languages. You can produce apps in 75 different languages, and getting a translator in is not optimal. We know that translation services in our hospitals are inadequate. We know that when families do them, they tend to be skewed according to the interpreter's agenda, and we know that interpreters are not trained in the sophisticated ways in which many doctors are to communicate information.
Do you think there's a risk of institutions trying to automate this process, because the internet can then move one step further to ticking boxes? And do you think there's a risk, because what I would want is to meet David and say, look, what's my operation going to involve? Do you think patients could be denied the encounter with a clinician?
Of course I want to meet David, but I want to meet him when I've absorb the information that will enable me to ask him questions. I don't want to walk up to him and say, David, tell me all you know about my condition. I want to have read about my condition. Most of what I read will bore me, and I'll put it to one side, but there will be things that interest me and things that I don't understand. And I want to go to him and say, I'm interested in this aspect of my condition. I didn't understand that. What's the real implications of that? And I want to use the opportunity to talk to him. It's precious. It's very expensive
is the information,
as well.
The encounter with the clinician is the counselling. Who should that clinician be? There is this theme now. You must be able to perform the procedure if you are to seek consent for it. Do you think that's, well, it's from the NHSLA. Should we be following this dictum?
I don't think it comes from the NHSLA, and I think it's far too broad a brush. I want to meet the doctor who's going to perform my operation. I want to meet him. I want to look him between the eyes. I want to know something about him. If I'm having cardiac surgery, I want to be able to look him up on the cardiac surgeon's website. I want to be able to talk to other cardiac surgeons and cardiologists and anaesthetists about him. I want to meet my surgeon. But on the other hand, the idea that consent should always be given by someone who's capable of performing the procedure. Supposing I wanted to have an abortion, not very likely, but it's one circumstance where we recognised that the ability to perform an evacuation of a uterus is very simple. It can be done by someone with very modest medical training, but the process of advising a young woman about the life problems that she is encountering and that the advice that she needs is highly sophisticated. And now most of the best London teaching hospitals or services providing abortion services have very sophisticated counsellors who won't have been trained to do the procedure at all. They will have been trained to counsel young women about the problems of unwanted pregnancy and controlling their reproductive function.
Yeah. I mean, the process of consent must involve the alternatives, as we said. So it must involve the options, which will come from varying specialists. So the team brings a lot of resource and knowledge to the patient. But is there a risk of losing control if the patient's seeing 5 different people who's advising them?
Yes, I think that's right. On the other hand, there are horses for courses. For example, there's a very sophisticated prostate service in this hospital, because of course this hospital absorbed the old St. Peter's and St. Philip's, and it's a great centre of prostate surgery and bladder surgery. Now, the advisory function for men undergoing prostate surgery is highly sophisticated, And yes, you want to meet the great urologist who's going to perform the operation and who's conducted the research which has taken it to a new level. Yes, you want to meet him, but you want an enormous amount of time in which you can study the data and answer the questions and try and get your own mind into a position. And you need more time than the consultant has got to give you. And you need somebody who is specialised in helping you to take those decisions. Almost always, at some point in that consultation, the patient is going to turn to the doctor and say, what would you do in my position? And the answer has to be, I'm not in your position. I'm 40 years younger. I don't know how important your reproductive and urinary function is to you. And I have to step back from that. This is a decision you've got to take on your own.
But the question will be asked again sometimes. There's much work that shows that there's the burden of decision-making at the final moment is heavy on patients, and they're still desperate for recommendation. Do you think that still fits with a modern model of shared decision-making?
Of course. Yes, you've got to give your advice. I want your advice. But I want you to explain, help me to take my decision, and giving me your advice has got to be directed towards helping me to take my decision. It's not telling me what to do. Remember the analogy of the pilot going down Southampton Water. You're going to give me all sorts of good advice. I've no doubt you're going to tell me to eat less, to drink less, to take more exercise. Of course you are. That's going to help me to get across the Atlantic. But you can be no more prescriptive in telling me to do an operation than you can be prescriptive in telling me to eat or drink less or not to smoke or whatever.
So we've talked about the resources, which will get better and better, I'm sure, and we've had decision aids for some years now. You've argued for a decision record. Can you tell us a bit more about that?
Well, that's partly because, as a lawyer, I'm aware that all legal cases are concerned with constructing the most plausible fiction of past events.
Yeah.
When the judge has to decide what happened, we can't take the judge back into the outpatient clinic to see what it is that you or David said to me. We have to construct it from the available evidence. And there's a basic rule in my trade that if it's not written down, it didn't happen. Now, if we're going to create viable records of advice that was given, including advice not to have surgery, including advice about all the alternatives, and to prove that when David advised me to have an operation, he also advised me about the advantages and disadvantages of conservative therapy, of surgery that's not available anywhere else in the country or not available in this hospital, then we have to step back and recognise that it's quite a difficult process. He can't sit there writing a viable clinical record. And we know that if I'm not laying down memory, even if he did write down everything that he said to me and he gave me an authoritative account of the options available to me, it wouldn't be sufficient as a process of teaching, as a process of communication. So I think that the outpatient clinic should be concerned primarily with creating a record of the advice that he's given me, and that advice should be primarily, or in many circumstances primarily, telling me where to go to read, and it should be telling me to go and look at audiovisual aids, videos, cartoons, things that I can read with my inadequate grasp of English or the written word. He should be in the outpatient clinic, he should probably be composing an email to me with a lot of standard paragraphs in it, pre-populated or populated as he goes along with single keystrokes, which will compose a long list of links reminding me of what it is that he's told me, telling me where he wants me to go and take my next stage of learning forward. And that should be the first stage in creating a decision record. There will be a previous stage, I hope, in the referral record, referral letter, which will record what I've been told by my GP, but that may or may not be there. So that's the first stage in creating the decision record. Then when I go to the hospital website and I look at the various things he's told me to look at, I hope that the hospital will create a record of the fact that I visited that website and a record of the learning that I've done. In my office, I have to, the health and safety gurus get into lawyers' offices as well, and I have to prove that it's safe for me to sit at my desk and work my computer. And I have every so often to go through retraining to prove that I'm sitting up straight at my desk. And I have to go through a record which records my learning. And we ought to have that sort of recorded learning process. Now, when I come back, I'm either going to see the doctor again, or I'm going to see a nurse in a pre-assessment clinic or whatever, and they should ask me whether I've done my homework and whether I've understood what's going on, and they should check that I've understood and check that I'm happy with what I've learned. If I haven't done my homework, or I haven't understood what I've been told, then I should be allocated to what we may as well call special measures.
Special measures.
And you will send me off to do more learning, or if I'm a slow learner, send me off to somebody who's more patient and who will complete the process. And that will be the second stage or third stage, because the third stage in the compiling of a decision record. When I come into hospital, the fact that I consent to the surgery, you ought to record the fact. I think it ought to be a little tick box on the WHO checklist that the patient consents to the operation is important. It's rather like as important as recording which operation it's going to have and which side it's going to have and all the rest of it. So we're going to record that. Then after the operation, I think that the decision record should have me coming back to the hospital and saying what I thought of the process and whether it matched up to my expectations. And that will be very good for your revalidation process, because you'll be creating something which forces you to be reflective about how good you are at communicating. It will force you to understand the limitations of your armamentarium and enable you to learn better about the consequences of surgical interventions that you routinely perform. In benign gynecology, for example, we have young surgeons who have to perform procedures on women they're never to save life, almost never. Almost always they're to relieve symptoms of pain, discomfort, or embarrassment. They are, by and large, not infallible procedures, and there are disadvantages involved in them. How is the surgeon going to heighten their knowledge, which will enable them to learn better which patients are over-presenting because they're intolerant of their aging process, which are under-presenting because they're diffident and they don't want surgery, which therapeutic interventions really work for these patients? How is a surgeon going to raise their own level of learning unless they see the patients afterwards?
So hopefully a more defensible record, a better recollection for the patient about why they decided thus, and ability for us to audit and reflect on.
And for you to learn better when you're counselling the next patient, if you are forced to confront. I lecture at the Royal College of Obstetricians about this, and I was talking about the value of this seventh stage in the decision record, how is it for you and how is it now for you? And they laughed. They said the commissioners now won't pay for us to see our patients after the operations. That's done by nurses or by GPs. And I give up. And we are further denuding medical education in the hopes of saving money.
Yes, this is the NHS under stress, trying to cut costs and everything. The day of surgery remains a very contentious time. Patients come in on the day, often with a new problem, a new lump has grown. Some decisions have to be made. This is the first time that anaesthetists might meet them. So what can we actually achieve in terms of decision making on the day of surgery?
Well, let's stick with the standard model. Let's forget the patient who's got a new lump, the first sign of a new cancer that they revealed to you on the day of surgery, and let's stick to the standard model. You should not be giving patients significant information and ask them to sign a consent form on the day of surgery. by the time they come in, you will have the money will have been spent. You will have booked a slot on the surgical list and in ITU and the bed. So the NHS has spent the money. And that is a slot which could valuably be allocated, forget money, valuably be allocated to another patient. So there will be enormous embarrassment for a patient if they give up,
pressure on them.
if they change their decision. Secondly, they won't be able to lay down information. They usually want to discuss these things with members of their family. They want to put it into context. They want to think about it. You don't take decisions quickly when you're frightened and anxious and about to undergo surgery. So, broadly speaking, we should not be giving patients information and taking decisions on the day of surgery. And if an anaesthetist isn't going to meet their patients before the operation, then let's take the anaesthetist out of the consent process altogether, because the decision's been taken. Someone else can see them and can record the fact that they consent. As far as the genuine new situation that arises as a result of new information being presented on the day, then that is a clinical judgment for you to make. You've got to decide how important it is. You do it all the time. You're always putting a stethoscope on a patient's chest and finding they got a sign of some sort of respiratory infection, and you say, do I go ahead or do I not go ahead? It's very much like that. It's any other clinical decision for you to take.
So let's say I said, I'm afraid Mr. Brown is indisposed, but Mr. White can do your operation today. If the patient says no, then we obviously respect that. But if they say, all right, then I'll give Mr. White a go, can we place reliance on their yes? Is that a safe thing to do?
Depends on circumstances. Broadly speaking, you have to. We can't run a service. But on the other hand, if you do want me to undergo surgery by Mr. White, I want to know, when did you first learn this? Why did it arise? Why couldn't you have told me beforehand? Very often you could do, and it's gross discourtesy to substitute Mr. White at the last minute if it's avoidable. But needs must sometimes, I agree. It depends on the nature of the procedure. It depends on how, whether if it's major cardiac surgery with a recognised mortality, where the identity of the surgeon is going to be very important to me, that's quite different.
But before we wrap up, I'll just come back to anaesthetists, as many of our audience will be anaesthetists. So now you've said take anaesthetists out of the consent process, but we can provide valuable information about outcome, about risks, which will be very important.
I don't deny that,
So
Andy.
where are we in this decision record-based process?
Many of my best friends are anaesthetists.
You've done great work for the college, I know.
I'm saying you have taken yourself out of the process. You are the one who said to me that you don't meet your patients before the day of the operation. If that's the way you're organising your professional life, then you are no part of the consent process.
Well, I meet other people's patients well before, so I can...
Well, then other anaesthetists can counsel me before I consent to surgery. But what you cannot do is to use the difficulties of the organising of your practice and your hospital and your professional life to force me to take decisions at a different time from when I really take them.
I think my problem is, even when I see them early, they've come to me resolved that I'm having an operation. So, as you said earlier, something in their mindset is fixed on the idea they're having an operation.
And there will be cases where your clinical acumen tells you there's something wrong here. This patient is taking this decision on a false basis. They haven't understood what's involved. And you, in their interests, as a doctor, may well have to say, sorry, stop. I go back. Please do not think that I'm here trying to teach you how to be a bad lawyer. I'm trying to help you to be a better doctor, and you should just be thinking clinical all the time. Is this the way I would want my mother to be treated? Is this what I would want them to be saying to my brother?
So let's say you have some time, a large amount of money and the authority. How are you going to change the way we advise patients in the UK? What fundamental themes can we try and export to
The first thing is recognise that it's now an integral part of medicine. The secular background has changed. Doctors are now in the process of teaching us. Second, the consequence of that is that hospitals and general practice and every other clinical level must be organised so as to give that the importance that it needs. And if we once get away from this business of thinking that what the doctor does is decide to do operations, then does operations, and at the last minute gets the patient to sign a consent form. If we once get away and get towards recognising that what doctors are doing is helping patients to take decisions, and very often those decisions will be negative. In America, where they've tried to do structured tests of decision records, they've found that they reduce the volume of surgery, they reduce the volume of complaints and litigation, and therefore they reduce the costs of running the health service. You move the costs into a different area, you spend more on counselling people, certainly, but there will be savings in other areas.
And what would you say to patients if you had 5 minutes of their time on television? Would you say challenge your doctors, or ask more of them, or ask more questions? What would you?
I'd certainly say that, but I'd also say own your own problems. If you think of the disasters that are happening, Michael Marmot's, the things that are shortening our life expectancy, they're decisions which are in our own power. You should be stopping smoking. You should be controlling your weight, especially if you are thinking of having a baby, for example. If you want to reduce the risks of parturition, then you educate young women to prepare themselves for that. And you recognise that pregnancy is the healthcare opportunity of 2 lifetimes, because the young woman is quite uniquely altruistic and concerned for her health when she is pregnant. And if doctors were to exploit that and to work with patients to use that information more constructively in a long-term fashion, that inclination, you would be getting this to go forward. But the empowered patient is not a soft option. Educating yourself to take your decisions. It's easy for me to walk in and say, David, you decide. I'm just a piece of meat. Doc, up to you. That's easy. And your job is to say, no, Bertie, I can no more do that and take responsibility. It's above my pay grade. You have got to take this decision. You're on your own. And I can only intervene on one day in your life. And you have got to take lifelong decisions. And I am here to help you to raise your own level of decision making so you take better decisions for yourself.
So hopefully society will go with us. And
society is going with you. Look at what's happening in our society. Life expectancy is going up. Marmot shows not only life expectancy, but disability-free life expectancy is going up. But it's not going up evenly. In the more deprived areas of our cities, it is still unacceptably distant from the empowered, educated, affluent areas of the cities. And what society has got to do is to support people to live better lives. And medicine is part of that.
Well, let's hope we can do that. Thanks so much for coming. It's been a great
pleasure.
chat, and thank you very much for joining us in the audience. That's it.
Thank you very much.
Thank you.
Cheers.